Hi, everyone. Welcome to this GI endoscopy session. And we're going to be sort of in the middle part of the GI tract with the evaluation of the small bowel by and large. So that's not strictly true, but welcome to you all. iEcho is hosted by the Gastro Foundation in association with Project Echo and on the Gecko message platform. These are weekly sessions on a Wednesday, and just to tell you that next week there is a public holiday, so there will be no meeting, but we follow on the 8th of May with IVD. And just remember that the chat room will be open for questions. Please post them there, and at the end of the interaction, please raise your hand if you want to speak and unmute yourself. It's always good to hear what you are and see you in the chat. So today it's billed as the capsule endoscopy, and I'm very grateful to Edwin Dietliff, who is on the program but not on the program. He couldn't make today, but I'm using some of his material as he is one of our sort of protagonists of using it in the private sector here, and when he was with us in Butiscure during his training period. So I'm just going to show you my slides, and we'll get going with the talk. Just let me know what view you have.
It's not in presentation mode yet. Maybe just swap it.
Yeah.
There we go. Yes, all good.
That's very good. Okay. So here you see Edwin. He spent some time in Amsterdam learning how both capsule and double balloon endoscopy worked. And he's still riding his bike, but largely over the trails in the Western Cape rather than in Amsterdam. I'm going to be talking about the capsule. It's been around essentially since around about the 2000s, certainly since its introduction into clinical use. And it's largely based on developments in miniaturization of cameras. And those are basically based on the CMOS chip. So they are a result of modern technology. They are swallowed, and the incumbent wears a device to which it is transmitting and records the images from the capsule. That is then downloaded onto an interpretation device where you can view the images, and has got software to help you interpret and scan the images when you are interpreting the study. Since it's been gone, since its inception, there are now, obviously, technology has improved further, and individuals and companies who make these devices are always trying to improve them. This is one of these devices. It's called the PillCam. And essentially what has happened is that they've improved the cameras, they've improved the viewing angle, they've improved the light control, and they really haven't, the one thing that they haven't changed is the size, which is 11 millimeters across by about 26 millimeters. And they're all the companies who make these are roughly that size. It's slightly bigger than most pills that you take, but it is easily swallowable. And here is a selection of these capsules that are available in the commercial market. Some, not all of them, in South Africa. And the PillCam is now owned by Medtronic, but it used to be the Given capsule, as far as I remember. And then there's this new kid on the block, the Capsule Cam, which is available in South Africa. And as you will see from it, it actually is a device, unlike the others, where the transmission is taking place to a device on the patient to transmit the images. This stores the images in the capsule itself, and you retrieve the capsule, and then the capsule can be downloaded just like a memory stick onto your interpretation modus, which is sitting in the cloud rather than necessarily sitting on your machine. There are devices to aid with the capture of the device, but other than it avoiding wearing a device to capture the images, this has that advantage. I just wanted to sort of, these are the capsules that are available now, and as I've told you, they are now capsules for the small bowel, which is where it all started. For the colon, there's a Crohn's capsule, and there's the patency capsule. There's now an esophageal capsule and magnetically controlled capsules. These are largely being used in the upper GI tract, but have the potential to give you a complete visual view of obviously a large structure, and also to control the position of the magnet precisely, and you can view the image real time, so that therapy, certainly in the upper GI tract, is possible with some of these devices. So just watch this space, but these are what are available. These are the publications over the years from 2002 onwards. And you can see that the colon capsule certainly seems to be gaining some traction, and that the magnetically controlled ones are also in the same boat. So again, this is a few years out of date, and as I say, largely these are driven by the manufacturer, because they obviously want to sell the product, but it comes with the interesting intellectual package of how we should use these capsules going forward. So that's the capsules, but obviously they're used for several reasons. Again, the most commonly used indication remains GI bleeding, but the other indications, and they are not so fringe now, are for suspected Crohn's disease, in polyposis syndromes, to monitor celiac disease, as I've said before, to detect colon cancer, and actually they may be used in a variety of settings in relationship to screening and mucosal healing and IBD. So they are increasing in their use, and we need to be aware of them and that they are around. I'm going to spend most of the time talking about obscure GI bleeding, and this is the algorithm that I think is pretty much up to date. And again, by and large, capsule endoscopy is used for occult bleeding and not for, as first line, for overt bleeding. Again, in overt bleeding, you're going to go to angiography first, and even CT scan, as there may be an actual pathology that is leading to the bleeding. So these are the way the algorithm works. And again, you can see exactly what happens if it's negative or positive. And again, depending on what's seen on the capsule, it may lead you into a therapeutic avenue. I'll come back to this algorithm a little bit later. It obviously allows complete visualization of the small bowel. And again, if you want to visualize the colon, you have to prepare it, that's for sure. It's painless, it's an outpatient procedure, and it directs enteroscopy. We'll come back to that again, because that's its main, shall we say, opposition or friend in the management of obscure GI bleeding. Obviously, it has a size, and if there's pathology that is going to narrow the bowel, such as Crohn's disease, it may well get stuck. So it's not really for use in individuals who have got recurrent small bowel obstruction or who have a known stricture. Again, it currently doesn't allow you to take histological samples, but these magnetic devices, which are steerable, may well change that exactly, because when they see the lesion, they may be directable by the magnet. Often obviously there's no therapeutic modality. Again, I've alluded to that with the newer capsules. And I think poor with certain pathology. Again, small ulcers may be difficult to see. It's not seeing the entirety of the small bowel mucosa. And so that's a negative. However, the technology and the cameras that are in them now are improving radically from the original versions. And so that with that better definition is going to come better definition of the pathology. Stuck capsules are nothing to worry about, really. They're low incidence, and you can see that it just occurs when you make mistakes or you come across an unknown individual with a stricture. And again, most of them are in inflammatory conditions where there are likely to be strictures or neoplastic lesions that are obstructed. Again, it's usually quite clear cut that you don't want to use them in these settings if you've been working the patient up properly. Again, I've talked about these. And again, similarly, you may get kinks and radiation disease that leads to stricture. This is the way you get around it. So if you suspect any of these things, you can use a patency capsule. Again, these are increasingly being used, particularly as the indications to do it in Crohn's disease have expanded. And again, these are soluble. They are the same size as the capsule. So if they pass, then you know for sure that the capsule will pass. And if they don't pass, you don't have to go and fix them out. And again, by and large, you can retrieve them, and many of them are actually radiopaque, so you can ensure, even if it's missed, that it has gone right the way through. Again, usually we're looking for mid-small bowel bleeding. And again, these are largely related to pathology that is often angioectasia. It may be ulcers from non-steroidal or from inflammatory bowel disease. It may be from tumors. Again, the small bowel is not a particularly common site for adenocarcinoma, but you do get melanomas and a few other lesions there. And again, it depends on the order of investigation, but if you suspect mass lesions, by and large, there should be some cross-sectional imaging, which may lead you into a different pathway rather than examining them for an obscure anemia, but using the capsule. And then there's the usual culprits that can occur there in patients with specific pathologies, which may be quite undiagnosed. A caveat of regarding the use of these devices, because often they may occur in patients who are on anticoagulation for either thrombosis or for prevention in those patients in atrial fibrillation. And again, it's very important to try and sort out the anticoagulation control and the need for non-steroidals and how they're taken, because what you're worried about here, one usually investigates these individuals, but the only reason that you're really doing it is to exclude that there may be a lesion which is responsible for the bleeding that has been unmasked by the increased risk of bleeding from the use of these agents. So again, there is a need to reassess the need for the therapy. There's a need to control the therapy and a need to get the timing of any gastrointestinal examination correct so that you can see what's happening. So the diagnostic yield, this is old data, but to be honest, it hasn't really changed. And you can see it's a wide variation in diagnostic yield. And again, it's approximately 60%. I'll show you some more up-to-date data on that. And again, it does depend whether you're dealing with overt or previous overt disease and whether they are actually bleeding at the time you do the procedure. Again, generally speaking, CE is done in stable patients, not in patients who have massive bleeding, but they can still be bleeding at the time of that. And obviously, vascular ectatic lesions usually don't bleed heavily. They often bleed intermittently and in small amounts. So you may catch them. And again, in occult, it's about 50% overall. Timing does matter. I've alluded to that before. And if you get the timing right, you'll see that it depends on exactly when you do the CE as to whether or not you're going to get that. And again, this is in overt obscure, where you do have someone who you know has bled from the GI tract with either melena or largely with melena or hematochezia. So the diagnostic yield from these you can see here, with angioectasia and generally ulcers being the top of the list. Or you may get some idea of the site of the bleeding without identifying the pathology. Again, you can see here how the days after the overt bleed, the yield falls off as you get further from the bleed. Here's some detection and completion rates that are from a recent article. And again, these are the indications that you can see on the right there, what we've been talking about mainly, but you can see Crohn's disease, neoplastic lesions, celiac disease. It's being started to be used there to monitor response to therapy and to see that doesn't remain atrophy. And again, the CS is for those with clinical symptoms, and you can see that the detection rate varies, but is roughly round about 60%. Retention rate and the completion rates are also pretty good, but you can see that the neoplastic group has the least chance of being completed. So it does give you good valuation of the whole tract, but obviously not of the whole mucosa. So obviously it's in some way it's opposition, but now it's much clearer that it's not in opposition. It really is the mode that you use prior to doing balloon enteroscopy, and we'll go into that in a little bit. So this brings me back to the algorithm that I showed you before. And again, if you have a positive capsule finding, you have to decide whether you're going to try and treat it. Now, angioectasia is the real big problem that you don't know, because most often when you see it, it may not be bleeding, yet you may attribute the bleeding to the angioectatic lesions. Again, there may be more than one. And again, the more there are, the more likely it would be, just from a mathematical point of view, that one of them has bled during the episode of bleeding. Again, they can be treated relatively straightforward with a double balloon, but remember, it has a reach and it may be possible to do total enteroscopy, but that is one of the limitations of double balloon, as I'll show you. Even in the best of hands, total enteroscopy is achievable, definitely not in 100% of cases. And again, if there's tumors or polyps, these again can be dealt with by the double balloon. And again, if you find a mass lesion, the treatment may well be that the patient needs a resection and could go straight to surgery. And again, if needs be and the bleeding is continuous and it's identified to be in the small bowel, i.e. you have the site of bleeding rather than the pathology of bleeding, it may be that you want to do laparoscopy and intraoperative endoscopy or even open surgery. Again, this is how the algorithm works. So total enteroscopy, as I say, it's possible probably in very expert hands in about 60 to 70%. That means you do it from the top and from the bottom. Again, obviously the CE allows you to direct where you think it is. Again, you can have a good idea where it is from the time of transition and actually what things look like. Again, you'll start where the CE identifies it, but usually it's from the top. And then if you don't find anything, you go from the bottom and go through the ileocecal valve and keep going. Again, these things are there, but they are very time consuming. So generally the first investigation, not the first prize, but the first investigation is usually to do a CE for obscure GI bleeding. Here's an example of the potential of the double balloon. You can see that it works by trying to concertina the small bowel, a bit like you would concertina if you wear the old-fashioned pajamas and you have a string on your pajamas, how you get that through if you pull it out accidentally. And obviously it's technically demanding. It's actually time consuming. It's not very pleasant for the patient, and it does have a cost. And if you're in private practice, it's not really very well remunerated. To be honest, it's a bit like watching a B movie. And it's quite tedious. Obviously, if there's therapy involved, it can be very challenging. This is the device that we use, and we've just replaced this instrument, having been without one for some time. The alternate endoscopy assist devices, there's one called the Spiral that Olympus makes, but they've discontinued it because of certain failures they've had in relationship to mortalities with the use of this instrument. So they're not devices that can't cause complications, and even the double balloon has got some drawbacks to it when you're trying to get around certain of the fixed corners. Again, here's just an example of how it sort of is meant to work, and it's a slowly concertinaing the whole business, both from below and above. Generally speaking, most of the time you're looking for bleeding, and hopefully if it's in the upper echelons of the small bowel, you'll get it from above. Again, here's total enteroscopy. They're almost right the way around to the ileum. You may not get there, and you can see that it's now entered the colon. Again, you can go from the top and tattoo, and then if you come from the bottom and see the tattoo, you can see it. Here's the sort of diagnostic yield, and again, you can see that it makes very much more sense to do this, to do double balloon after you do capsule, and that it may be in certain circumstances that if you identify a non-mass lesion or ulcers, that you're going to manage the patient expectantly before you would consider moving to DBE. So that's how things work now generally in units that are using these devices in lots of patients. So this is the sort of thing that can happen. And again, you can see that you may be left with a cause, or you may be left with a negative outlook. Again, you can see truly negative output is very low risk, but when you have a positive, there is definitely a yield in terms of them rebleeding. And again, it may be difficult to establish the pathology, and you may have to have a wait and see policy and manage them with iron therapy. Again, sort of, you can do the sums, and I think it's almost certainly best to do the CE first on cost grounds, because it's going to exclude individuals from more invasive procedure, which again may or may not be successful. So there's the risk of rebleeding, and again it varies depending whether it's overt or occult, and again it depends on what you found at the time. Again, I've told you that generally speaking, you want to manage lots of vasculitic lesions with APC, as it's relatively safe and it may well solve the problem, but not always. I just want to say a little bit about future trends. Again, I've alluded to some of the developments of the capsule, the movable capsule, and the fact that therapeutics are coming for the capsule that are going to be controlled by magnetic forces outside the body. Again, you can see the usage here from the different types, and the esophageal capsule and the upper GI capsule, magnetically cleared, are actually being used to assess people with routine upper GI bleeding in America. Again, we haven't moved in that direction. And this is the colon capsule. And again, you can see it's being used to monitor colonic disease, usually inflammatory disease, ulcerative colitis. And it's being used as part of screening initiatives based on the FIT test. Again, I think its main use is, again, as an alternate to those who have an incomplete colonoscopy, which, remember, in the best of hands is probably about 5 in 100, but might be as high as 1 in 20. So there is definitely a market there. And obviously the other contenders there are, in fact, CT colography. So again, there's comparison studies being done using the colon capsule in this setting. But its Achilles heel is related to, again, preparation and how you do that. It's obviously a much simpler alternative to colonoscopy, but in the end of the day, you have to decide exactly which way you're going to go with this investigation. And I think if you start to use it, you're going to have to spend a lot of detail preparing these patients well for it. So what is really coming is artificial intelligence. I'm definitely not an expert on this, but I basically understand machine learning better than one learns AI, because obviously AI independently can work things out once you give it enough information. But most of these devices that are working on visual cues, like the polyp detection tools that are now being used in colonoscopy, are being, the initial steps are with machine learning. You take images of the exact pathology, and you match them up with the pathology gold standard, i.e. removing it or getting histology. And then if you've got enough of these, the algorithm will tell you exactly what it is. It will be able to characterize it. And again, the more information you feed in with machine learning, the more the computer has the capability to start to learn itself. So this is definitely coming, and it's been on the go for about, well, I would say 15 years, certainly with machine learning, to try and improve the yield. And also, the idea really is to remove the manual interpretation of these scans, which is time consuming, even with the current software that's available. So this is coming, and it will, in my view, make things more accurate, more diagnostically accurate. And so it's going to increase the use of these devices and simplify their use. This is sort of trying to understand what happens when you get to advanced AI, because they start to interconnect the information that you're giving them themselves. And the more information you feed into them, the more the hidden layers will improve the correctness of the output. The degree of similarity to the brain, I think, begs explanation. So my take-home messages are that CE is ever evolving. Obscure GI bleeding remains the main indication, and other indications are definitely catching up, including therapy. They're more than on the horizon. They're being used in clinical settings now. The yield will improve with AI, and AI is coming fast to the table. Again, even if you identify the cause or the site, it may not solve the problem, but at least it usually excludes some other problems. So I hope that's given you an insight into the general idea and concepts in capsule endoscopy, and that it's provided you some insight as to how it's being used. I'm happy to take any questions, and I'll just end my show now. I see we have a few people on the call. It would be interesting if anyone has any questions or queries about it. I know some of you are using these devices, but they are largely considered tools that are perhaps not used in lower income countries. Vikash, I see you're in the corner there. I saw you in two places. Your hand is up. Please unmute yourself and let us know what you're doing and up to.
Hi, Prof. Firstly, thank you for an excellent overview. I think it was very comprehensive and you covered pretty much everything. As we evolving with Capsule, we now have systems where you don't actually need the entire system, the belt and the receiver. And there's these capsules where the patient actually just retrieves it and you just post it off in the mail and it goes off to or via the cloud, and you get an automatic report and automatic feedback. Do you think this is the way to go forward? Because one of the issues is so freely accessible, so free to do, easy to make money with in private, but also opens up the door to people who actually have no endoscopy experience or GI experience, just doing capsules in their rooms, and which ends up being a money-making service. So potentially leading to misuse and overuse of capsule as well.
Yes, I think so. One of the capsules that I mentioned is indeed that capsule. It's now, I mean, it's obviously storing the information on the capsule itself, so it has to be retrieved. Again, I think there are a variety of ways it can be analyzed once it comes out, but it certainly obviously can, it's almost like a memory stick. You can plug it into your own machine, and that's how it gets to the, it's going to transmit to the cloud. But the software to interpret it is sitting with, rather than sitting on your computer, it's sitting in the cloud. And again, a lot of the have developed algorithms to shorten the interpretation that will take you to identified lesions, to identified sites. So I think just machine learning will improve that further. Obviously, machine learning depends to extent on how many examples you've got to analyze and how frequently the capsule is being used. So the more it's being used, the better the machine learning can work. So I'm sure there are lots, I mean, I don't know quite what the usage is now, but it must be phenomenal. So some of the data sets, but traditionally, if it's one video source, it will only be that video source which is used for machine learning. I think that's slightly different in the way that machine learning has been done for the adenomas, because it's purely image interpretation, and the images are essentially similar no matter which endoscope they're coming from. Yeah. But I think the capsule, the images are different, and the images, they're all messing around with the angle of view and the light intensity. So I think those two things, you know, may make machine learning a little bit more difficult until the capsules had huge usage. But yes, and I think it's being used, you know, as an alternate to endoscopy, which is not pleasant. And so even upper GI bleeding, again, obviously you want that to be transmitted real time, but you can evaluate the stomach for, especially in individuals that you want to discharge. So I think in America, it's so, and in Europe too, it's so expensive to admit a patient that it's much better to do an investigation that will exclude them having a serious problem that needs admission. So I think increasingly they're being used in that context, just as CT is being used to exclude appendicitis. It's highly accurate, and then you don't need to admit the individual. So, Chris, sorry, I see your hand up there.
Yeah, no, Sandie, thanks so much. And really, I appreciate you coming in here at the last minute. And I just want to resurrect a discussion and a study that we actually put together, a few years ago, which unfortunately didn't get the funding. And that's that on our continent in sub-Saharan Africa, with, you know, poor access to endoscopy, and with the kind of reality that perhaps centers of excellence in the 4 regional areas in sub-Saharan Africa would do the kind of therapeutic endoscopy, that perhaps Capsule could be used as a screening tool for those patients with non-specific abdominal complaints, which you would normally subject to upper or lower endoscopy, in an area where colorectal cancer doesn't seem to be very rife or, you know, have a very high prevalence. Do you think that capsule endoscopy could be used as a kind of screening tool in those kind of scenarios? It would then prevent a lot of patients going through unnecessary endoscopies from a diagnostic point of view, and could be used much like we use MRCP to screen those patients that would, you know, that benefit from therapeutic ERCP.
I think, again, obviously they're obviously trying to get better resolution, more sophisticated capsules, and obviously that must come at an R&D cost, I would say. And so I think until the price of the capsule becomes competitive.
Putting the price aside though, because once you have something that has a use, numbers will and volume will then obviously hopefully lower the price. But in principle, from a medical evidence point of view and the practicality point of view, do you think it's something worth pursuing?
I think anything that reduces the number of invasive procedures that you do is a good idea in general. And MRCP is a very good example of that. And even the FIT test is now moving into symptomatic patients. So patients with chronic constipation, for instance, if if you're 70 and you have chronic constipation and you have a negative fit test, why should you have and again there, if you want an even further confirmatory examination, have a colon capsule. So I think it has very good rationale for making things safer and less invasive and excluding risk. How you roll it out in Africa with financially and that way, I think would be the real challenge if you want to move it in that direction. To me, that would be the challenge.
So you find so payment, cost would really be the major challenge, do you think?
Yes, cost and availability, and yeah, and then obviously the reading thing of it. Vikash,
Well,
do you
that
want
could go
chime
straight to
in?
cloud with these new.
Yes, no, I think again, once people are starting to use satellite directly to upload them. Vikash, you want to come in again?
Yeah, no, I think you basically answered it already, but I was going to say, yeah, I mean, it often takes longer to read a capsule than it does to perform a colonoscopy, so time does become an issue. But if you do have outsourced services like cloud-based services where someone is able to read it for you and generate a report, and that certainly addresses the time issue. I wanted to just ask from your experience and perhaps from many of the members in the audience, because you've done quite a bit of training in other African countries. Is there a lot of access at the moment to Capsule in places outside of South Africa?
So I do think, I mean, my understanding in most of the places is that there are private hospitals, and that medical insurance, as we know it, is under 5%. So they're catering to a market that is insured in the state sector, and I do, yeah, certainly in Kenya, I think in Ethiopia there are private institutions which are using it, but I don't know of any state institutions that I've visited that are. And again, I think that is, even if it is in the private sector, it is one way that you could pilot these sort of things to see if they start to become economically viable to do. Because endoscopy is an extremely scarce resource, and the dwell time for a capsule for upper endoscopy, for instance, is small. If you can capture all the images and exclude that they've got an ulcer, then it would be a very valuable investigation. But obviously that's the cost of the capsule and the cost of the device to transmit the images and look at them in real time. Otherwise, it's not really effective as a diagnostic tool for upper GI bleeding. But it is being used in the States, definitely, to do just that. So I think it's far away from getting into, you know, mainstream volume in African countries.
Yeah, just to further allude to your point with regards to screening and non-invasiveness in upper GI bleeding, there actually was a paper in GIE, I think 2 or 3 months back, a different type of capsule called Pulse Sense.
Yeah.
And basically you can pop that capsule in, you know, in a casualty type of setting. And what it tells you is blood detected, blood not detected. And it detected blood with I can't remember exactly, 90+ accuracy. So then triaging patients essentially who would then require an upper scope after popping in the capsule.
Indeed. Yeah. So yes, I think it's tricky to see where it's going, but I think you know, as they get refined and as this cloud interpretation becomes easier and that becomes more mechanical, you take the chore of the capsule out of it and move it into, you know, a relatively easy to use device. So anyway, is there any questions from anyone else on the call? We're happily to take anything, even if it sounds basic or not, and we can try and answer it. If not, it remains for me to thank myself for stepping into the breach. But basically, I've worked for a long time with Edwin, and I appreciate his contribution to some of what I was telling you today, especially about the obscure GI bleeding. And again, thanks to Echo in Mexico and India for whose platform we are, iEcho in India. And remember, these will be available on the Gastro Foundation website as a recorded talk. And just to thank again everyone who's been attending, and keep attending, and again, give us feedback as to what you would like and what we need to offer to you. So on that note, I'd just like to wind up the meeting, and thanks to everyone.
Thanks, Sandie. Thanks so much for filling in. Thank you.
Not at all.
Cheers.
Take care. Cheers.